Delighted to meet you, Melissa, and really interested in what research you're doing and particularly how it will affect esophageal cancer. The reason I'm interested is 10.5 years ago, I knew absolutely nothing about esophageal cancer. And then I got a diagnosis of it and I Googled it, and that's scary. But I went into treatment here in St. James's under the great team that John Reynolds had then and still has. And I did chemotherapy, radiation, and then surgery. And after that surgery 10 years ago, I've recovered and I'm cured. But I'm really interested to know how people like you can find out more about cancer of the esophagus. What are you doing? What is the research now?
Thank you so much, Seán, and lovely to meet you, and congratulations on your survivorship, and you look really great, so that is just great news and very inspiring for someone like me. So just to talk a little bit about my research, you mentioned esophageal cancer. So just for those who don't know, esophageal cancer is cancer of the food pipe, which connects the mouth to the stomach. And unfortunately for esophageal cancer patients, the vast majority do not survive past 5 years. So while we've massively improved survival rates over the decades, only 1 in 5 patients will survive past 5 years. So that's quite a stark reality, and that's something that we want to change. So what we know is that the vast majority of patients don't survive. One of the big reasons is because 70% of patients don't have a durable response to the therapies. So how can we change this? How can we provide hope and give new options to these patients? Well, I'm an immunologist. That means I study the immune system. So that's the body's own defense system. And what we found over the past number of years is that in esophageal cancer patients, the immune system is highly dysregulated. So what we want to do is we want to fix that using drugs known as immunotherapies. So immunotherapies harness the defense system of the body, and they promote, let's say, the killing of the cancer to improve survivorship. And they're showing success across multiple cancers. So that is my goal.
So there are times when the immune system just doesn't work at killing cancer cells. Do we know why that is?
Exactly, Seán. The immune system is very, very complex. What we know is that the immune system can be dysfunctional, so not working properly in people, and then it can be made further dysfunctional or can even be manipulated by the cancer itself. It's a really, really complex network. So I'll just focus on one story, on one part of our research, is that we found a very, very important type of immune cell called a natural killer cell. And the clue is in the name, okay? Natural killer cells are really important in killing cancer. What we found is that these cells in the most obese esophageal cancer patients, and the reason I say that is because esophageal cancer is established as an obesity-associated cancer. So unfortunately, there's a really high risk of developing certain cancers when individuals are obese. So in the state of obesity, in esophageal cancer, what we find is these key natural killer cells cannot get to the tumour. Instead, they are pulled into the visceral fat, or as some people call belly fat, in these patients. And so our goal is to redirect those immune cells towards the cancer so that they can reach it and kill it.
Okay. Mm-hmm. And for that, you want to find some drug that will help, or how will you redirect the immune system to do what you want it to do?
Great question, great question. So I suppose over the past 9 years, we've been looking at this problem, looking at the immune cells. They're there, they're just not in the right place. Mm-hmm. So how do we move them from one place to another? Well, the body actually has a GPS. It's called a chemokine system. So it's its own GPS, and it tells the immune systems where to go and when to go there if there's a wound or cancer or a virus or a bacterial infection. So we're going to exploit this system with therapeutic intent. So what we have found is a molecule called fractalkine. is produced in abundance in the visceral fat. And we've used specialized models to show that this molecule is pulling the natural killer cells into the fat at the expense of going to the tumor. So we've also identified a way of blocking this molecule. So we found a drug, it's called a CX3-CR1 antagonist. It's a bit of a mouthful. And what this drug does is it blocks fractalkine from pulling the natural killer cells into the fat, allowing them to move towards the tumor.
Okay. So how do you get from the stage where you know this might work to actually developing the solution to make it work?
Mm-hmm. Okay, yeah. So with thanks to Breakthrough Cancer Research, who have funded a research program, the next step, now that we've identified a way to block fractalkine from misdirecting the cells, is we want to test this drug in preclinical models. So before we go into clinical trials, we always have to perform rigorous preclinical studies. So over the next number of years, we are going to move our studies into these preclinical models to test that this drug is effective and will actually move the NK cells from the fat into the tumor.
Okay. How will the new drug targets get to the patients?
That's a great question, Seán. So we know that we see this kind of figure being thrown around, that it's 10 to 15 years from bench to bedside. And that is an average. So as you know, we've been working on it for the past 9 years, some people longer. And so over the next 3 years, we will perform our preclinical studies. Once we perform these rigorous studies, more preclinical studies may be needed before we get to the patient to make sure that it's both effective and safe. And once we're happy that the drug will be effective, then we will move towards human clinical trials. And hopefully showing success then in clinical trials, it will be offered to those 70% of patients who don't have durable responses to chemoradiotherapy and surgery. And we'll have another option, hopefully, for them.
That's the really fascinating thing, that, so many people, they don't get cured by the chemo or the radiation or the surgery, or haven't up to now. But you're finding new ways of dealing with those cases.
Exactly, yeah. And already there are options, immunotherapies, options that are approved for these patients. And actually, only around a fifth of those work also, and we think that's because the immune cells are not in the right place. So this might be an immunotherapy that's used with another immunotherapy, hitting the tumor from two sides to really boost that anti-cancer immunity and destroy the tumor.
Yeah. So how is it that your work actually will benefit patients now and in the future?
Excellent question. So, it can be sometimes frustrating when you're a scientist because it's a long process and it takes a lot of work to get from one point to the next, and lots of hours. And I must thank my PhD students. They also put in lots and lots of hours to actually generate the data that we need. So how it can impact them now, it may not impact patients right now, but we hope in the coming decades that this work will generate new drugs that offer them options when the current therapies no longer work. It will be another option for them to increase their survival.
Really great, really impressive. Tell me, Melissa, how did you get into this?
It's a very long story. So I think I joked earlier that it was either going to be science or drama, right? So I always loved biology and loved learning about the human body. And so after completing my PhD in immunology, I went into the pharma industry for a while, but I really wanted something more. I wanted to be closer to the research, to the translational research. So I came to the Department of Surgery in 2012, and I started my postdoctoral studies in 2013. And since then, I have been undergoing, really thorough training within a really multidisciplinary team that I'm honored to work in, and getting to meet patients and, working with people who are dedicated to providing samples to us so we can perform the studies. So over the past 9-10 years, I've been performing these studies, and that has kind of brought me up to now. So it's a real passion of mine, and I love it.
What's really amazing, the 10 years I've been watching this, is how so much has come together so well here in St. James's with the Trinity input, John Rillans and his team. A year or two ago, I learned about now we're using keyhole surgery. Imagine if I'd been able to have all this done through keyhole, or even robotic surgery is coming. And all the time, of course, you're working too to improve the understanding of what's causing this to happen, how we can deal with it, even without the most severe interventions. It must be really great to be part of that.
Yes, it's very exciting. And the Trinity St. James's Cancer Institute is a hub of innovation. You've got really passionate consultants like Prof. Reynolds and Prof. Lowry, who are really focused on getting the most sophisticated therapies into patients. So as soon as we can, moving into clinical development to get shorten that bench to bedside period that we talked about earlier. So it's really nice to be surrounded by people who are passionate about helping people and improving survival. And as you say, we're probably, who knows if we will ever replace the chemo, radio and surgery, but we can definitely offer more hope to people when those standard of care stop working or cease to work for them. So that's what everyone's goal is.
And the results are improving all the time because knowledge is developing and that knowledge is being applied. It may take a few years, as you've explained, but it's really worth investing in that knowledge to improve the prospects, to improve the treatment, to improve the outcomes.
Absolutely. So there's important questions that we have to ask before we develop a drug or introduce it to a patient. For instance, what are the off-target effects of this drug or this pathway? And we need to know more about these biological pathways before we can, introduce drugs. So the basic scientific research is how we discover these drugs. It's how I discovered that fractalkine was a key player in misdirecting the immune cells. So without that, we'll come to a standstill. So it's so important that basic research and translational research are funded.
Yeah.
Yes.
That's been a really great explanation. Thank you very much, Melissa.
Thank you, and thank you for giving up your time. I'm honoured to meet you.
Thank you.
Thank you.
I'm honoured to meet you.
No, and I really mean that.